Let's talk about orotic aciduria. It's a common topic in biochemistry, especially for the step 1 USMLE. So what is orotic aciduria? It's a rare inherited disorder of pyrimidine synthesis because of the deficiency of the enzyme UMPS, which is uridine monophosphate synthase. It is inherited in an autosomal recessive fashion. So this enzyme is deficient due to the mutation in the UMPS gene. And this enzyme uridine monophosphate synthase has two activities: orotate phosphoribosyltransferase transferase, and number 2, OMP decarboxylase. OMP is orotidine 5 monophosphate, and both of these activities are needed to convert orotic acid to UMP, uridine monophosphate. So before we go any further, we have to revise the purine and pyrimidine synthesis pathway from first aid book. We can refer to the page 34 of first aid book 2024 version, which I have. Let's look at the pyrimidine base production on the left side. So in the pyrimidine base production, this pathway requires aspartate, and it starts from glutamine plus carbon dioxide. Glutamine plus carbon dioxide become carboxyl phosphate. This reaction needs 2 ATP, which is converted to 2 ADP plus inorganic phosphate plus glutamate. And the enzyme needed here is CPS2, which is carboxyl phosphate synthetase 2. It is number 2, CPS2, not CPS1. CPS2, because this pyrimidine synthesis happens in cytosol and found in most cells. CPS1 is from urea cycle, which happens in mitochondria and found in the liver. Okay, here it is CPS2. Okay, so glutamine plus CO2 becomes carboxyl phosphate, and carboxyl phosphate is converted to orotic acid in combination with aspartate. When carboxyl phosphate combines with aspartate, it becomes orotic acid. This orotic acid combines with PRPP, which is phosphoribosyl pyrophosphate, PRPP, which comes from pentose phosphate pathway. So PRPP comes from pentose phosphate pathway and combines with orotic acid and then becomes uridine monophosphate, or UMP. So this step, where orotic acid combines with PRPP converted to uridine monophosphate, needs uridine monophosphate synthase enzyme, which is impaired in orotic aciduria. Okay, so this is the main step that is broken in this orotic aciduria. So in orotic aciduria, UMPS is deficient. UMPS is required to form UMP, which is uridine monophosphate. Uridine monophosphate, or UMP, is essential to make uridine, cytidine, thymidine, and DNAs and RNAs. So what happens in orotic aciduria? If UMPS doesn't work, it cannot convert orotic acid to UMP. So orotic acid accumulates. So there will be low pyrimidines and impaired DNA synthesis. So rapidly dividing cells like bone marrow will suffer. What kind of clinical features you will see? So there is classic triad, which is megaloblastic anemia. It doesn't respond to B12 or folate, and failure to thrive, and orotic acid in the urine will be found. But it's important to remember, in orotic aciduria, there is no hyperammonemia because it is not urea cycle defect. No hyperammonemia, and liver function is normal. Okay, no hyperammonemia and liver function is normal in orotic aciduria. Why we have megaloblastic anemia in orotic aciduria? Because there will be low pyrimidines and the DNA synthesis is defective, so bone marrow produces large immature RBCs. So it looks like B12 or folate deficiency, but the levels are normal. B12 folate levels are normal. So what's the treatment? Treatment is to give oral uridine supplement. So uridine will bypass the block restores UMP and decreases orotic acid, and it will correct anemia. It's very important that you need to differentiate between orotic aciduria and ornithine transcarbamylase deficiency. So a very similar condition where you will see high orotic acid is ornithine transcarbamylase deficiency. So both orotic aciduria and ornithine transcarbamylase deficiency both have high orotic acid. So where does ornithine transcarbamylase act? It acts in the urea cycle. We can refer to the urea cycle in First Aid book at page 80. So in the urea cycle, carbamoyl phosphate plus ornithine, it becomes citrulline. So ornithine transcarbamylase helps this reaction, carbamoyl phosphate plus ornithine, to become citrulline. It needs ornithine transcarbamylase. It happens in mitochondrial matrix in the hepatocytes. So after the citrulline is formed, it moves to the cytosol for the rest of the urea cycle. So what happens in the ornithine transcarbamylase deficiency? If ornithine transcarbamylase is deficient, it cannot form citrulline. So carbamoyl phosphate accumulates and ammonia increase, hyperammonemia occurs, and orotic acid will also increase because excess carbamoyl phosphate enters the pyrimidine pathway. So you will see high orotic acid. This ornithine transcarbamylase deficiency is X-linked recessive. Orotic aciduria is autosomal recessive. Ornithine transcarbamylase deficiency is X-linked recessive. And ornithine transcarbamylase deficiency is most common urea cycle disorder. So it's X-linked recessive, so the case will be male infant. It will come with vomiting, lethargy, respiratory alkalosis, high ammonia, high orotic acid. So let's review quickly one more time about the difference between orotic aciduria and ornithine transcarbamylase deficiency. One important point is that both conditions can have high orotic acid. The real key is to ask one more question. What is the ammonia level, and do we see anemia? So in orotic aciduria, the problem is in pyrimidine synthesis. The enzyme missing is UMPS, uridine monophosphate synthase, which stands for, normally UMPS helps convert orotic acid into UMP. If UMPS is not working, orotic acid builds up because it cannot be converted. Since UMP is needed to make pyrimidines for DNA, the body has trouble making DNA properly. So what do we see clinically? We see megaloblastic anemia. It does not improve with folate or vitamin B12. The problem is you cannot make pyrimidines normally. The patients will also have poor growth or failure to thrive, and the urine has high orotic acid. The most important distinguishing clue: in orotic aciduria, ammonia is usually normal. Why? Because the urea cycle is not blocked. The issue is in nucleotide synthesis, not ammonia detoxification. And the treatment is also very important. You give uridine. Uridine bypasses the block and helps the body make uridine monophosphate. And that improves DNA synthesis and improves the anemia. Okay, now it's turn for ornithine transcarbamylase deficiency, or OTC deficiency. Okay, this enzyme is part of the urea cycle. It acts in the mitochondria of the liver cells. It normally helps convert carbamoyl phosphate plus ornithine into citrulline. If OTC is deficient, the urea cycle gets blocked early and the ammonia cannot be converted to urea properly. What happens? Ammonia rises, hyperammonemia occurs, which can lead to vomiting, lethargy, irritability, and encephalopathy. In newborns, it can become severe very quickly. But why does orotic acid go up in OTC deficiency? This is the bridge between the pathways. When OTC is blocked, carbamoyl phosphate builds up. the extra carbamoyl phosphate gets diverted to the pyrimidine synthesis pathway. That pathway produces orotic acid, so you end up with high orotic acid in the urine. So now we have the classic comparison. Both can have high orotic acid, but only OTC deficiency has high ammonia. Also, anemia is not a classic finding of OTC deficiency. The main issue is ammonia toxicity, not DNA synthesis in the bone marrow. Another difference is OTC deficiency is X-linked recessive, found in male infants. Orotic aciduria is autosomal recessive. Okay, next, let's talk about a classic USMLE style scenario that tests the difference between orotic aciduria and urea cycle disorders. The stem might describe a toddler who is not growing well and is a bit delayed. For example, imagine a 15-month-old boy brought in for poor weight gain and developmental delay. The parents say he still has trouble standing without support and has very few words. On exam, he looks small for age. Then the question gives you a few lab clues. You see hemoglobin is 8.9 gram per deciliter, mean corpuscular volume or MCV is 112 femtoliter, so the red cells are big, and reticulocytes are low, and importantly, the plasma ammonia level that they give is normal. Then they hit you with this key urine finding. The urine shows increased orotic acid or large amounts of orotic acid crystals. Now the question asks something like, supplementation with which of the following substances would most likely benefit this patient? And the answer choices are usually vitamins and nucleotides. The choices would look something like, okay, A, ascorbic acid, B, folic acid, C, guanine, D, iron, E, pyridoxine, and F, uridine. So, how do you think of this? We hear macrocytic anemia, very high MCV, low reticulocytes, failure to thrive, and increased orotic acid in urine. This points towards a problem in pyrimidine synthesis, specifically orotic aciduria, due to UMPS or uridine monophosphate synthase deficiency. What separates it from OTC deficiency or ornithine transcarbamylase deficiency is the ammonia level. In OTC deficiency, ammonia is high because the urea cycle is blocked. Here, ammonia is normal, so it is not a urea cycle problem. This is a nucleotide synthesis problem causing impaired DNA synthesis, which is why you get a megaloblastic anemia. So the best supplement is uridine, because uridine bypasses the enzyme block, helps generate UMP, and improves DNA synthesis and anemia. So the correct answer is F, uridine. And one last testy reminder, if they give you the same orotic acid finding, but the patient had severe vomiting, lethargy, and very high ammonia, then you would shift to thinking OTC deficiency, not orotic aciduria. Okay, that's all for this podcast. Good luck, everyone, and have a good day.